Welcome back to Money this evening. We're discussing healthcare. My guest is Ron Whelan, and if you'd like to email me any questions, you can do that to info@anchorcapital.co.za. Just coming back to that, I just want to, I don't want you to lose the trend, but I do want to ask you a question. If they had removed, and I was surprised, because we've been hearing for a long time they may remove the medical credits that we all get as taxpayers. Would that, how much, any idea, and maybe this is just a stab, any idea what that would have, what that would give Treasury?
It's a good question, Brian. So as I said, we've got to raise 200 billion rand. The removal of medical tax credits wholesale across the sector would raise somewhere around 30 billion rand. Okay. So it's a fraction of the 200 billion rand that we need to get raised. I think it's also important to point out that medical scheme tax credits are a very progressive funding mechanism in that it's a fixed rand amount per principal member and per beneficiary per month. So what it does is it actually benefits the lower income earners to a greater proportion than higher income earners. And if you were to remove medical scheme tax credits, it would likely result in about 2 million people immediately having to move out of the medical scheme industry as a result of that. So you've got to be we've got to be cautious.
It just wasn't as simple, say, moving. You've got to look at all the consequences of doing that.
Definitely a lever, but it would result in a significant deterioration in the affordability of medical schemes, and as a result, people being unable to afford medical scheme cover and then becoming a burden on the state and public facilities. So I think this is probably what has weighed in Treasury's considerations in the latest budget speech. But coming back to NHI, so I think the first thing is it's a big amount of money that needs to be raised. Secondly, even if we were to raise 200 billion rand, we likely wouldn't achieve the levels of universal healthcare that we aspire to achieve. And thirdly, even if we were to raise it and get the fund together, it would result in quite a significant deterioration in the healthcare benefits that medical scheme members currently enjoy. In fact, to such an extent that healthcare funding available for medical scheme members would drop by about 69%. So effectively, the NHI proposal is an increase in tax rates of by circa 30%, with a reduction in healthcare benefits by about 69% for medical scheme members. And that becomes a constitutional issue because in terms of Section 27 of the Constitution, we need to drive progressive realisation and no regression in the rights of the population.
You know, Ron, I did some calculations this weekend. No increases in tax. It's not actually correct because there was no bracket creep. And I did the calculations this morning, someone earning 250,000 and someone earning 480,000. No increase in tax credits or medical aid. If you got a 5.5% to 6% increase last year, you are now paying you're into a new bracket, whereas normally that bracket creep kept you in the same bracket. So whilst it was a clever ploy, we're not increasing taxes. Everyone is going to pay slightly more if you got an increase in the last 12 months and no increase in tax credit for medical aid. But let's just talk about the one concern that so many people have. Why in this country would we ever consider, if you go into NHI, not allowing you to have private healthcare?
Yeah, I think...
Am I putting you on the spot?
Yeah. So Section 33 in the NHI bill says once the NHI is fully implemented. Now that's an important point, Brian. Once the NHI is fully implemented, nowhere in the bill does this define what fully implemented means. It says once it's fully implemented, medical schemes will only be able to provide complementary cover to the existing NHI benefits. And complementary cover, in other words, top-up cover to the benefits. The implementation of NHI is likely many, many years away, if not decades away. As I mentioned before, we've first got to figure out how to fund NHI, and Treasury has to develop the so-called money bill for that. Secondly, have to do a significant restructuring of the healthcare system. And one of the parts of the restructuring of the healthcare system is that we need to centralize all of the provincial health budgets into a single national health budget, so an NHI fund. That is a significant constitutional challenge and operational challenge. And then thirdly, need to implement NHI. So I think we're not anxious around NHI being implemented anytime soon. In fact, we see the implementation over several years, if not decades, which means that there will be no impact on medical scheme members for the foreseeable future. Now, if this all plays, if we're able to raise the funding, if we're able to drive the regulatory changes and the structural changes and get NHI implemented, you're right to say that there won't be a role for medical schemes, but there is a long way to travel and significant water still to come under the
Because
bridge.
every other country you can have private healthcare. If I think about the UK and other countries that have NHI, you can.
We've done an analysis on this, Bryan. We've found 19 countries globally that don't have a private healthcare funding infrastructure, and those are typically war-torn countries, those are typically fragile states, or typically very small countries. Even countries like England, where there's a very well established and well funded NHS, has private health insurance. So roughly 19% of the UK population accesses private healthcare insurance. The same thing happens in Ireland. The same thing obviously happens in the US and many other European countries. So it's a small number of countries where there is no private healthcare insurance. And we think we in South Africa certainly would benefit from a multi-funded model where there is crowding in of healthcare funding into the system rather than a single funder.
So let's just talk about Council for Medical Schemes. Who are they and why haven't they passed? I mean, we've got this problem. There are many many people who would like cover, but you can't buy low-cost schemes yet. Why?
It's a good question. So the Council for Medical Schemes is the regulator for medical schemes and medical schemes administrators in South Africa. The job of the Council for Medical Schemes is to ensure compliance with the Medical Schemes Act. So they are our regulator, if you will. And they play an important role in the sustainability of medical schemes in South Africa. They also play an important role in protecting consumers and medical scheme members. So they have complaints lines and investigation processes, and they're an important arbitrator in making sure that medical scheme members achieve the right benefits. They also, as you say, are responsible for developing new regulations and guidelines. And one of the regulations and guidelines the Council for Medical Schemes has been tasked with developing is the low-cost benefit options. And this is a piece of work that has been in the throes for several years now. I'm pleased to let you know that the Council for Medical Schemes has now developed a low-cost benefit option framework, which they have now sent to the Minister of Health and the National Department of Health for review and consideration. It has taken a long time to get there, and we are hopeful that the low-cost benefit options will be approved sometime soon. And the reason we're hopeful for that is that if we have low-cost benefit options, it allows an influx of an additional 4 to 6 million people into the medical scheme environment, admittedly at a lower benefit structure than medical scheme members currently enjoy, but at least it puts them in the door around high quality private healthcare cover.
Well, this is an appeal to our Minister of Health. Please get that bill signed off. I think it's very important. I'm going to go to some emails, because why should I let you off easily? Because the email is the one that tests you. It says, I've got a doctor who's anonymous. He says, please explain why as a network doctor we've had a much lower increase on our tariffs for 2024 than the increase on your medical aid. I can't comment. Is that correct?
No. So, I think it's important to point out, and I think part of the question is we often get questions from doctors and saying, why is my increase at somewhere around CPI, whereas medical scheme contribution increases by CPI plus 3 or 4? The reality is the underlying cost drivers for a medical practice versus a medical scheme are different. For a medical practice, medical practice inflation is largely inflation-based. It's your rooms, it's your receptionist, it's your own salary. My salary also goes up by a CPI. I don't get a CPI plus 3 or 4 salary adjustment every year. So
come on, Discovery, after Ron. Come on, man.
Thank you for that, Bryan. I would appreciate that. Whereas medical scheme inflation is different in that medical scheme inflation, as I mentioned earlier on, is driven by an aging population, higher chronic disease, medical technology, and so on and so forth, which drives a higher inflation rate to cost contribution. It doesn't mean that we pay doctors less. In fact, what you see, Bryan, what's interesting around doctors is that while the tariff increases are at CPI, because of the increased demand on doctors and the increased utilization on doctors, the actual revenue increases. The amount that doctors earn on an aggregate basis every year are up significantly higher than CPI. And that in many instances is justified because they're working harder because there is greater demand on the system.
Well, Philip in Barberton says, please could you demystify the difference between a medical aid and a medical insurance?
Very, very important question. Medical schemes, as I said, are governed by the Council for Medical Schemes and the Medical Schemes Act. Medical schemes operate on a specific regulatory regime where they are community rated, they have prescribed minimum benefits attached to them. Everyone pays the same contributions. Medical insurance products, on the other hand, are not governed by the Council for Medical Schemes and do not fall under the Medical Schemes Act. They fall under the Short-Term Insurance Act. So you do not have prescribed minimum benefits in health insurance products. You do not have prescribed minimum benefits in health insurance products. You do not have community rating in health insurance products. So there are very, very different mechanisms. And we've seen across the South Africa environment, there are a range of non-medical scheme products. There are some gap products, for example. There are primary care insurance products as a further example on that. There are hospital cash plans as an example on that. It's important that consumers are aware that those products typically have limits attached to them, whereas if you're in a hospital for a medical scheme, you will have the benefit of prescribed minimum benefits and typically unlimited hospital cover.
And what they need to understand, it doesn't replace medical aid.
Doesn't replace medical aid.
I really apologise to all those that I've not been able to get to the emails. I will get back to you, and if not, one of my healthcare consultants will. One of the prime issues raised in our healthcare slots has been the importance of members understanding their benefits and a full appreciation of whether they're on the correct plan. Even if your cover seems adequate, there's no harm in evaluating how effective your scheme is and compare these with other options with your medical aid, which may be more cost effective or even provide wider cover. For those in retirement, the biggest increase to your monthly cost is your future cost to medical aid. And in retirement, it's probably essential to have a medical aid. Ron, thank you for joining me this evening. It's important to note that our programs provide information and should not be construed as advice. Next week's program will focus on estate planning, and if you need to get hold of me, my details will appear on the screen. I'd like to thank you for watching, and good night.